Ultrasound is really nothing more than an extension of the concept of percussion and auscultation. And this goes back hundreds of years. And what the technologists were able to do, instead of relying on tapping on your finger to palpate the rim of a liver, for example, they've been able to incorporate that similar technology, a way of injecting sound waves into a body and then listening for the echo, and based on understanding that echo, interpret what's going on within the body. And that's actually one of the fascinating things about this from a history standpoint, in that we've been doing this for hundreds of years. We're just getting better at it. The most common procedures for ultrasound in the ED would include the FAST exam in the settings of trauma, which is essentially a focused, limited cardiac study and abdominal study. We're using it more in renal patients, particularly in people with a history of kidney stones. And we can use ultrasound to assess them with regards to subsequent presentations with pain, thereby reducing their exposure and their risk for radiation. And this has been one of the areas that I've enjoyed watching, because it's a patient safety issue. With regards to patient safety issue, I would say another big area is ultrasound-guided central lines, where we can really reduce the risk of pneumothorax or injury to the patient, instead of the classic blind procedure, using ultrasound to have positive control, know exactly where the tip of your needle is. Another patient safety issue is actually deep peripheral lines. Many times patients have had to have central IVs because of poor peripheral access, but with the use of the ultrasound in the emergency department, now we can get deeper peripheral lines. We can really reduce the patient's risk and exposure to central IV access, and get them what they need, get the tests that they need with peripheral. Here in this institution, we're using ultrasound in the emergency department for pregnancy localization. If a woman presents to the emergency department under 20 weeks with a positive urine pregnancy test with the complaint of lower abdominal pain or bleeding, residents are doing the necessary ultrasound imaging here to determine the location of the pregnancy. And that's been something relatively new to us over the past couple of years. And it's actually now become one of our more common and more consequential exams. The issue with ultrasound at the bedside oftentimes becomes a real estate issue. As the evolution of ultrasound has migrated from performing focused, limited studies of exams that one might get in other parts of the hospital, let's say a right upper quadrant ultrasound or a renal scan, and the role of the ultrasound has now become really wedded to the assessment of the critical and unstable patient. You find yourself with your ultrasound machine and your ventilator and your EKG and respiratory, and you end up getting, you get this huddle of people around sick patients. And it can become problematic to get in there and get the necessary exams. Some of the limitations of the technology, for example, is these ultrasound machines. We have 3 in the department right now. They work great when the lights are off. It's kind of hard to run a code when the lights are off. And you get into some of these unanticipated issues trying to get high quality images. So the technology is moving in a good direction, but it's not quite there yet. All right, we had a young gentleman who came in with exertional hyperthermia, and he was very unstable. He was intubated by my residents, and shortly thereafter he became hypotensive. The background is he'd only been in the race for about 20 minutes. He came in sweating profusely. And with regards to evaluation for his hypotension, one of the things you need to worry about in exertional hypothermia is whether or not you might have actually a primary cardiac insult. So we were able to assess his left ventricular cardiac function. It looked normal. His right ventricular function looked normal. Trying to assess his right atrial pressures, they actually looked low. So we know he's at least dry and possibly peripheral vasodilated. So it took one of the issues off the table, and that is, does he need an inotrope? Because although the heart is at risk in hypothermia, it's not involved in this particular instance. What that test showed was that his gallbladder and collecting system was normal. He presented with right upper quadrant tenderness and pain, and had some mild elevations in his liver enzymes. And one of the issues that we had was he developing, particularly with a slightly elevated white count, was he developing an infection in or around his gallbladder. The ultrasound machine reaffirmed what we already knew with regards to his liver disease. But it also gave us some encouragement, and the encouragement was his gallbladder was normal, normal wall, no thickening, no stones, no sludge, no evidence of infection. So it really took a lot of potential serious diagnoses off the table, and now we're able to focus on his underlying disease and how to manage the pain of his underlying metastatic liver disease. With regards to availability, it's actually good news that we're having issues. We have a department here, about 30 beds. We have 3 ultrasound machines in this department. There are now there's a couple generations between the newest and the oldest. And what we're finding is more and more residents are using these machines in their bedside evaluations. And not only that, the nurses are using these machines to help them with their IV skills. So sometimes you have to kind of wait in a queue to get a hold of a machine. And that can be a problem if you're impatient or you're in a hurry. The issue of training is it is a real issue, and we're looking at a continuum. I think if you take a look at the ultrasound and you recognize that it really is a tool that is augmenting your physical exam, what you have to recognize is the more you do, the more you pay attention to your physical exam, the better you are at it. And it's the same thing with the ultrasound machine. The more you do, the more you use it, the more you troubleshoot, the more you recognize variability in patients, the better you get at it. And it's a time thing. It's like learning an instrument. And there are folks who pick it up naturally, and there are folks who struggle with it. But that said, at its core, asking simple binary yes/no questions with relatively limited training, you can answer some very important questions. Ultrasound is now part of the core curriculum for emergency medicine. And when a resident graduates from any accredited program, they will have a core knowledge set for the competent use of ultrasound and the evaluation of the patient. And that begins, in this program, it begins the first month of an internship, where we will put them into lab training as in their first year of internship to learn some of the basic concepts, the knobology as it's called, certain core examinations, the FAST exam as one example, and this will continue through their 3-year education here. There is a rotation in their second year, and in their second year there is a month where they spend additional time with me or another faculty who have a background in ultrasound to work on additional skill sets. And they will continue this education through their 3 years here. Bringing ultrasound to the patient bedside, particularly an unstable patient, I think is the clinician who is apt to embrace the technology, a much cleaner, more accurate assessment of the patient's physiologic status. And I really very much encourage that in my resident's approach to the unstable patient. Example, a patient presents into our resuscitation room and hypotensive. Without the use of ultrasound, you go through your usual differential and your basic physical exam. And you can come up with a differential and act on that differential. The nice thing about ultrasound is it brings to the bedside a much finer, focused ability to assess the patient. For example, you might think the patient may be hypovolemic, but you can approach and you can take a look at the patient's right atrial pressures, and you know if the pressures are high or low based on the ultrasound. It gives you good objective metrics that reinforces your clinical assessment. You might assume that the patient is in cardiogenic shock. Well, you can, by taking a look at the patient's heart, you can confirm or perhaps refute your clinical impression that the etiology for hypotension may be a primary pump problem. And not only that, if you've identified that it's a pump problem, you can drill down even further and decide if this is a pump problem due to volume. It could be a right ventricular issue, a left ventricular issue. A whole host of possibilities are included or excluded when you bring that technology to the bedside. When you bring it to the patient's lung, it is a great test. It is much better in many instances than a plain film chest x-ray for diagnosis of pneumonia, diagnosis of failure. It is the best test in the room for pneumothorax in an unstable patient, particularly if in the context of a trauma patient. It gives you the ability to see and hear inside the patient. It really gives you the ability to hear what the patient is telling you when you're trying to guide your care, particularly in a time-sensitive fashion. There may be other imaging technologies you can get to in the hospital that might give you better, more definitive information, but they're not at the patient's bedside, and that's information you just may not be able to otherwise retrieve in an unstable patient.